Well, welcome everyone. This is the second webinar of the year for physical medicine and rehabilitation. And what is exciting about tonight is we're kicking off a physical medicine and rehabilitation webinar series. We are actively gathering data on autologous biologic treatments specific to physical medicine and rehabilitation, which we will present in the upcoming series as we gather more data. We will be having Q&A session at the end of the discussions tonight. So we encourage you to make the most of tonight's webinar by entering your questions via the Q&A chat at the bottom of your screen. This evening, we are fortunate to have 4 esteemed physician panelists with us providing invaluable information on advancements in regenerative medicine applications for the PM&R provider by way of PRP, protein concentrate, cellular therapies, and talking cash pay for regenerative medicine. Dr. Bert Mandelbaum is currently in Paris for the Olympics, so we are fortunate that he was able to pre-record his discussion for us. Dr. Bert Mandelbaum is a leading orthopedic expert, graduated from Washington University Medical School and completed his residency at the Johns Hopkins Hospital. He now works at Cedars-Sinai Kerlan-Jobe Institute, affiliated with UCLA. Renowned for his research and contributions to sports medicine, he has served as a team physician for UCLA Athletics and LA Galaxy. He has also played vital roles in FIFA World Cups and the Olympic Games, earning accolades such as honorary doctorate from the State University of New York in 2009. Dr. Jason Dragoo is the professor and vice chair of academic affairs for the CU Department of Orthopedics and endowed chair of regenerative medicine. He has developed many procedures designed to augment the healing of a patient's own body. He is also the head team physician for the Denver Nuggets, as well as consulting physician for the U.S. ski team. Prior to this, he was the head team physician for the Stanford football program for 13 years. Dr. Marc Gruner specializes in the prevention and treatment of sports medicine injuries at Ortho Bethesda and Washington Sports Medicine Institute. He completed his fellowship with the leading experts in ultrasound and regenerative medicine at Mayo Clinic, residency at Georgetown University, and medical degree and MBA at Virginia Tech. He is passionate about value-based care and regenerative medicine and extends his teaching to ultrasound learning at the national level. Dr. Ariana DeMers is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. With that said, we're going to go ahead and get started with Dr. Mandelbaum's pre-recorded segment.
I look forward to having the opportunity of sharing with you, and the title of my talk is Orthobiologics, Precision and Personalized Use to Impact Injury Burden and Play Span. A lot of what we have learned over the years has been from athletes, and I'm a sports medicine doctor, as you could see, and those lessons to affect how we can reduce the burden of injury and improve play span is really what I'm going to focus on. First concept that we have is injury burden. Injury burden is really the frequency of injuries plus multiplying it over lost days. And you can see in all sports, as you see in this paper about soccer, it's about hamstrings, ACL are the chief injuries that really cause a burden within our sport. In addition, another concept, number 2, it's about play span. Play span is a new concept that we've introduced, which is really the amplitude over time, which is seasons, time, and years. It can be a career, but also a lifetime. As you can see here, King Kazuyoshi is really the oldest soccer player. So he's figured out how, in fact, he can improve play span over time, and he's done that very well. We're going to talk about some of those concepts in relationship to orthobiologics. Now, as we well know, the future for orthobiologics is bright. We can see a significant amount of global market size increasing over time. And we also realize that it's going to follow the innovation diffusion curve by Rogers, which is to go from innovators, early adopters, early majority, late majority, and then the laggards. So where we are here somewhere getting to the tipping point, but we're not there yet. And we're really going to speak to the family of orthobiologics going forward. Now, understand, we're kind of limited, as we all know, by the FDA in terms of regulatory issues. So most of the focus we have now is not on this list of stem cell products, umbilical cord, exosomes, amniotic fluid, and Wharton jellies, but really more on autologous type of interventions. So we're really focused on approaches that we call adjuvant therapy, substances, interventions that can work together so we can do better by improving the efficacy going forward. And why? The field of oncology has been amazing when you think about it. No adjuvant therapy, 39.1%, adjuvant therapy, 74.2%. But that is not unique to oncologic processes. We know from the standpoint of regenerative medicine that we see the adjuvant regenerative triad. It always requires cells, scaffolds, and growth factors. If you're just going to throw cells in and not affect these other parts of the equation, then we're not going to achieve optimal results. So again, it's all about the synergy. It's all about the triad going forward. So let's start with one of the more common injuries that we see is really that of hamstring injuries. And again, tremendous amount of burden. So how do we deal with this challenge? How do we create a solution going forward? Well, one way is, and you can see from this paper coming from Stephen Cohn and from Philadelphia, when they had 27 athletes with grade 2 hamstring strains, aspiration and injection of PRP, as you could see this GPS biomet system, and they found that they could decrease the number of days, the burden, by 8.9 days, but more importantly, they impacted the re-injury rate, the re-tear rate, by 24.6%. It was decreased, really making a big difference. So the future is trying to figure out in who and when. And again, a lot of medicine is out in front of us. AI and digital twins are really focused on reducing the burden. You can develop personalized models, predict prognosis, and efficacy to optimize therapy, just like this.
Hello. I am a cancer patient digital twin. All this clinical information, thousands of data points from x-rays, scans, genetics, lab tests, pathology, has been combined to create me, a personal avatar.
A personal avatar. And for us in sports medicine, it may look like this in terms of taking all those factors all together and trying to figure out how to thread the needle. The digital twin avatar, the future is now. We just need to have apply it to what we're doing. So let's take an example. Here we have early OA and a 25-year-old professional soccer player. You clearly can see the joint space narrowing right there in the lateral compartment as compared to the other side. The elevator is going down. More catabolism than anabolism. So concepts in thinking this going forward. Claudius Galen was actually the first sports doctor, surgeon, philosopher, physiologist who told us athletes overindulge. And guess what? They live shorter and get arthritis. And they do. Here's NIH commissioned studies show that in soccer players, odds ratios 5.1 to 12 times greater in those soccer players. We also know that athletes, as we can see from Colin Fuller's paper, a third of them retire with a clinical diagnosis of osteoarthritis. And when they retire, they even have more osteoarthritis, but also then combining with mental issues. We see it also in Brazil in a paper we wrote with Moises Cohn, decreased quality of life, increased pain and symptoms, and knee OA. So it's not only when they're playing, it's after that represents the problem. So we come up with a concept. He and all athletes are the master of their fate, captain of the soul, but guess what? The cartilage is the master of their soccer football career and beyond, and beyond. And we'll speak to this in a minute. Remember that the knee is an organ, just like that beating heart there. We must consider everything, alignment, meniscus, ligament, complex molecular issues and matrix issues in the bone, cartilage, synovium, and the secretome. And as you can see right here, the interaction between the cartilage, the bone, the synovium, crosstalk goes on. And constantly we have to think about all of these variables. So we look at this, we look at the natural course. For example, if you have a meniscus deficiency, there's a 15 times greater likelihood to have a total knee replacement. And here, if you tear your ACL, a 7-fold greater likelihood of having a knee replacement. So where are we in orthobiologics? We want to disease modify and push them off the curve like that. And that's how all of us as physicians, whether you're PM&R, orthopedic surgery, primary care, whatever you're focused on is exactly this going forward. We want to push them on, improving their symptoms, decreasing their pain, and avoiding a knee replacement for as long as we can. So again, switching the weight, decreasing the progression, away from catabolism towards anabolism. How do we do that? We have a list of things, everything from corticosteroids to WNT pathway inhibitors and everything in between, and I'm going to speak to it at this point. We'll start with glucosamine. We know in systematic review, Mike Shikati has told us that in fact you can protect the cartilage and delay osteoarthritis progression. Even melatonin, as you can see in 11 trials, it significantly decreased the levels of interleukin 1B, very statistically significant. HA decreases in inflammatory response, improves viscoelastic properties, protects cartilage degeneration, and it has a degree of specificity. That low molecular weight is not as efficacious as high molecular weight, and very statistically different, especially when you look at the CPG guidelines of the WAOS that show that only the high molecular weight meets the standard of clinically important improvement, MCII, and it meets the threshold only for high molecular weight. So it brings us to PRP. And let's go over those ABCs in that alphabet soup. First, it's about Buffy code versus plasma based. And that Buffy code sits right there. Platelet concentration is important. WBCs may be important. Activation, very important. And dosing could be important. So all these variables have to be considered in this very robust multifactorial equation. But how does it work? Lots of papers, as you can see, from 2014 to 2021 about mechanism of action. But this is what it does. Here in the agar plate, the MSCs swimming away, and guess what? They're summoned by the PRP. They swim over there. Once they get there, they replicate, proliferate, and then have a very positive effect on cartilage, metabolism, and regeneration of synovium, meniscus, and chondrocytes. All of these are very interactive, just like we talked about that triad. You can see coming off the periocyte, the MSCs, the PRP interact, replicate, and then create a positive effect. That's how it works going forward. But we also know when we cytokine profile after injection, we can see that it's anabolic and anti-inflammatory by stimulating that proliferation, potentiating SOX9 transcription, and elevating COL2A1 and ACAN expression. How about efficacy in clinical use? You can see these papers, all in 2021, showing significant improvement over time. But again, not all the time. And in this paper, it really showed, Bonsall et al. Shows it requires 10 billion platelets, 10 billion to achieve a long sustained chondroprotective effect. Also corroborated by our study, where we found that there were more platelets, there was better responders, green, more platelets versus the non-responders. And we see this in several studies. This is from Laura DiGirolamo, and in fact, we can see that in this category, high platelets, VAS score 0 to 10, high platelets, 3 months, 6 months, 12 months, all green. And at the end of the day, more platelets, better response with respect to pain and overall improvements. But again, we can manipulate this just by taking activation with calcium chloride or thrombin. At rest, the platelets look like this. Platelets activated, they look like that. More functional after stimulating. And exercise mobilizes PRP. As Adam has shown, vigorous bicycle exercise significantly increases concentration of platelets by 20% and statistically different. Personalized, predictive, preventative participatory approaches by our patients. Adjuvant therapies, taking HIA and PRP together, the HIA stimulates and induces the release of more TGF beta 1 and PDGF factors from the PRP. Seen in clinical studies, there are 7 studies, systematic review, HA plus PRP is better than PRP alone. And Brian Cole from Rush has shown that PRP and HA is a greater improvement than HA alone. So we learn more because we bring in other macromolecules such as alpha-2 macroglobulin.
The shape of the leaf, turning it into a trap.
And it acts just like a venous fly trap. As you can see here, the proteases line up, the fly trap closes, and then it takes those and puts those out into the bloodstream. So it inhibits the proteases and therefore is one of the major functions. It decreases the level of MMPs, TNF alpha, and neutralizes interleukin-1 beta. At the same time, and this is the power of this molecule, it increases the expression of cartilage protective genes. And Jason Dragoo in his talk will talk more about this going forward. We can see from the group of Laith Jazraoui from NYU, they conclude that A2M has similar effectiveness to corticosteroids and PRP. So what are we now? This is a work in progress, but we're now using high molecular weight HA-PRP and A2M. Again, more boldly trying to switch catabolism to anabolism and limit progression. But why are we focused on this? Again, I talked about mortality and morbidity. And this study by Angelico Mendy, an epidemiologic study, found that if you have osteoarthritis, you have a 1.3 greater likelihood, hazard ratio of dying early. And if you have arthritis less than 40, it goes up to 1.53x of dying with cardiovascular disease early. So the implications of osteoarthritis are extremely powerful with respect to our simple osteoarthritic patients that we have to pay attention to going forward. So how do we think about this? And again, you can think about longevity. And remember King Kazu over there, but also David Sinclair has given us aging treatable through vitality genes, epigenetics, and has given us a list of things that we can do that affect these pathways called the sirtuin, AMPK, TOR, and other systems going forward that improve longevity. We also know Dan Buettner has given us about the blue zones of all the things that we need to do to help us going forward. So we have applied this to what we call the play span in career and life. And we know that if you have arthritis, your curve shifts this way. And as Peter Attia has shown us, that if you could push it the other direction by increasing the play span, the amplitude up and out, as we've shown in people like King Kazu, following all of these things, we can improve our play span, quality of our life, quantity of our life, which is our ultimate goal as physicians. So what do we learn today? And again, it's going to be a great meeting and webinar. Precision medicine, the devil is in the details. Specificity, devil's in the details when it comes to biology. Specificity of platelet numbers, use of activators, understanding the triad. All these details are critical. And most importantly, you need to know that adjuvant therapies are synergistic and they will optimize our results, therefore lowering the burden, and most importantly, improve the play span, the quantity and the quality of our lives. Thank you, and have a great rest of the meeting.
We'd like to thank Dr. Mandelbaum for taking the time to pre-record a segment to share his insights. We are now going to turn the time over to Dr. Jason Dragoo to dive into protein concentrate.
We're excited that you're here with us to talk about some really new, exciting technology. And as Bert talked about, biology really is about the details, and my talk is really all about the details. And just wanted to show you some new science that has come that may help us on our quest of treating our patients. And there's been a lot of science, of course, through the years of PRP. And as most of us know, one of the waste products of PRP is platelet poor plasma. And for many years, that's been thrown away. And then we kept the platelet rich fraction. And then as time goes by, there's been some real amazing things that have been discovered in platelet poor plasma. And with that, there's been some really good technologies that have been able to harness these exciting scientific molecules that are in the plasma. And that's what I wanted to share with you guys here today. So this is all about the plasma concentration, otherwise known as fluid volume reducing devices. And it is true that there are many companies that do manufacture these fluid reducers or these filters. But what we have is a new technology here with Apex, and I want to show you the power of it because I think that's the thing that's enticing to me. The devices on the market, as you can see, which are the predicate devices, otherwise known as PC-P, those are the ones on the market, and you see this is the pore size, 65 kilodaltons. But with the new technologies from Apex, you see that the pore size is much smaller. And that gives us some opportunity to be able to filter out other things in the platelet poor plasma that the other filters just can't, just because of the technology of the filter. And so this presentation here is about the science of putting actual patients' blood and plasma through these filters. Here's a little bit about the design of this study. So 120 cc's of blood was drawn from 12 donors, and 60 was used in the Apex concentrating device, and 60 was used at the comparator. And then what we wanted to do is we wanted to look at many things within the blood, including whole blood, PRP, platelet poor plasma. And because of using the filter system, we also care about what's in the water that we're extracting. Like, are we missing some molecules because our filters aren't that good? And so therefore we're leaving things in the wastewater again. That's exactly the reason we're using these plasma concentrators. So we're putting everything to the test. Well, here's some data that we've previously released, and again, showing that the blood, the platelet poor plasma, is processed in exactly the same way in these groups, right? 12 in each group. And in the summary, what it led to was some very different results between the two filters to begin with. The first is that the Apex filter, because of the technology, removed much more water, right? So we started with 30, and then with the Apex device, about 20 to 24 cc's of water was extracted. And that was a comparison to the market where it's 7 to 9 cc's. And of course, then that left with a very different a platelet poor concentrate. So with the Apex device, there was 4 cc's of much more viscous solution, and with it was double the amount of volume with the predicate devices. And with that, the things you trap are concentrated, right? So for instance, overall, there was a similar number of platelets that were filtered out by the devices, but you see how the platelets were concentrated, right? Double than the current market, and that's because of, again, of the concentration of the fluid volume. And so this is useful for us when we're trying to trap very specific molecules within the blood. This is just showing again that the output of the apex device just performed better than the predicate. But again, it wasn't that it actually trapped more platelets, but more platelets were being able to be concentrated in a smaller volume. And again, that could be very useful for our clinical applications going forward. Well, here's the roadmap of the science project here of what we wanted to do. We're interested in these biologic molecules, some of which Bert talked about, some of which he didn't, and I want to really go over some of these here. And let's just kind of put this through the test, right? Can these filters actually give us concentrated products in these very biologically active molecules and proteins that we have here? What you're going to see is that from the top of the chart, as Bert said, A2M, it's a huge molecule. It traps, harmful enzymes, etc. Well, that's totally different, right, than some of the smaller ones, such as platelet-derived growth factor. That has a size of 25 kilodaltons in comparison to 720. So you see, the more that we can trap out of this platelet-poor plasma, the more potential we have with regards to its biologic activity. And that was the goal of this exercise. And I'm going to go through some of the molecules highlighted in yellow just to kind of explain the utility of the potential utility of this and also the results of this investigation. So same picture as Bert used, right? The venous flytrap. And of course, we know that this is a potent protease inhibitor, and it really helps control the inflammatory environment of our blood. And so it's a large molecule, and you say, well, this should be a chip shot for all of the filters because it's so big. So, let's look at the data. Well, the first is that you see with the first graph to the left, there's very little A2M in whole blood. There's concentrated. There's very little concentration in pure P, and of course, just standard platelet-poor plasma. It's just not concentrated. But you see both filters do a good job of concentrating this A2M to a much higher levels of nanogram quantities that can be theoretically scientifically useful. And with that, we're concentrating at roughly 5 times, and then the apex filter roughly 1 times more than the standard. But again, this is expected, right? Because this is a big molecule, but this is exciting. There's a couple of other A2M concentration devices that are available on the market, but they're expensive. It's very lengthy to process the plasma. So this just gives another alternative. And I think this is just really exciting right from the beginning of trapping these large molecules. But of course, it doesn't end there. So let's get a little bit more into the nitty gritty here, and let's go down to IL-1RA. So as I think everyone on the call knows, that IL-1 is a potent anti-inflammatory mediator. So just to be clear, the receptor antagonist neutralizes IL-1, right? The more IL-1RA is floating around, the less effect that IL-1 will have on our bodies and the receptors. And you see this cartoon where if IL-1 comes into the receptor, then it activates the inflammatory cascade within the cell. But if the IL-1RA comes into the receptor complex, activation is blocked, and there is no activation of inflammation. So this is really critical for controlling inflammation and symptoms within our soft tissues. And so we not only care about concentrating IL-1RA, but we care deeply about this ratio, right, of IL-1RA to IL-1, because it's crucial for the effect. And we know from data around the world that there needs to be somewhere around 100 to 1, 100 ratio of 100 molecules of IL-1RA compared to IL-1. And so that's where we're kind of looking for a clinical effect of this. So let's see how the filters did with this. So this is a smaller molecule, right? So this is 25 kilodalton. And so I guess with that, it wasn't a surprise for me to see that the apex performed better, significantly better. And the reason is, of course, the pore size. And so then that was kind of expected by me, but the filters are performing. with this. And so I think this is great that, there is no system in the United States that you can use for IO1RA. You can in Europe, right? There's a couple of them, but not in the United States. So this would be the one where you could really concentrate IO1RA. The other is that what was the ratio, right, of measured IO1RA to IO1? And sorry, the equation there is flipped, but the bottom line is that the Apex achieved a ratio of 100 to 1, which in other studies it showed clinical significance of this ratio. So I think that was really exciting news for this. And now not only do we have A2M, but we have IO1RA concentration at clinically significant ratios. So that's great. And then, the question is, well, where do we go from here? And one of the next things that we want to do on the scientific agenda of Apex is we want to apply these filters to leukocyte-rich PRP, because with that is where the monocytes are, and monocytes can increase the amount of IO1RA. And so maybe we can even have filtration of leukocyte-rich PRP, which we haven't been proven this yet, right? But may increase this ratio of IO1RA. So stay tuned for an upcoming webinar, as we'll keep releasing the science when we get it. But again, exciting, discovery number 2, and it certainly doesn't stop there, because let's keep going around this soluble receptor level of around 25, 26 kilodalton. The same thing is true, right? IL-1 is a big inflammatory cytokine, but so is tumor necrosis factor. And there's a lot of similarities. And although TNF and its cascade is much more complicated than IL-1, it acts differently in that TNF is controlled by soluble receptors. And so it's much like this cartoon, that there are receptors for TNF on the cell surface, but there's also these soluble receptors that are floating around right in the plasma. And so then these TNF alpha can be then locked into these soluble fragments, and then again inactivates the effect of TNF. So it's the counterbalance that the body naturally has to make sure that these molecules are not too concentrated. So in the same way, we really need to concentrate much more of the soluble receptors in comparison to the TNF. And, as we look at the data, we see that both the soluble receptors, the TNF soluble receptors, can be trapped with the filters, and again, significantly better as you use platelet poor plasma on the right side, right? This is the right diagram. That you see that the Apex was able to trap more of the soluble receptor, significantly more in comparison to the predicate. You can trap this from PRP2. It just, again, it gets you really around the same levels, but even can be concentrated further, as you see from the graph in picograms here, with the platelet poor plasma concentration. So that's excitement number 3. As far as the filters are concerned, and we're certainly not done yet, because again, right around this 25 kilodalton is something else really important in our plasma and in our PRP, and this is the platelet-derived growth factors. And they're not all the same. There's 3 forms of them, but the form that is the BB fraction of it is the one that is responsible scientifically, so this has been shown, to release the perivascular cells, right? So these are the pericytes that are around our blood vessels. Let's just call them the MSCs, because they're in that same working family, that are released from their spot in the perivascular space and then into the area of need by this platelet-derived growth factor. So if you wanted to use cell medicine, then you would give cells right to the body. But this is kind of the great in between, right? If you say, but I want to use a plasma-based treatment, but I want to activate a local stem cell, or the MSC, I should say, niche, then this could be a real good in between, right? Because this would be activating the local niche there around your area that you're working. So, bottom line is this, that the filters again worked, and but here's the summary again: platelet derived growth factor. These are in the fraction of platelets. So if we really wanted to increase the amount of platelet derived growth factors, we would be looking to PRP fraction, not platelet pore fraction, if that makes sense, right? But I want to show you that even with the platelet pore, right? Even if you're concentrating platelet pore plasma, look at the filter concentration. So we're able to concentrate this still. And again, Apex did better. Why? Because it's a small molecule, right? So it's a smaller filter or pore size. So then it acts more efficient on it. And that's what we see from the capture of platelet-derived growth factor. And so next step is very similar to IO1 RA, and that is we're going to be testing the PRP fractions, right? We want to know how much we can concentrate of this platelet-derived growth factor, and then we'll study this as a factor that we can use in biologics and to see its benefit locally within our soft tissues and our joints. Epidermal growth factor is one that I was interested in from the science perspective, from from the filter performance perspective, right? Because this is really small. This is 6, and our filters are 50, and so are we going to be able to trap it? But the other is that it may have some benefit within our epidermal cells, right? And there's lots of specialties within medicine that use these products, these biologic products, and including skin therapy after burns, et cetera, and post-operatively. So this might fit in. I don't know where it fits in orthopedic surgery and sports medicine, but nonetheless, we want to study it. And at the very least, we want to see if we can really recover it. And as you see, we're able to recover it. No surprise, the pore size of the apex is better. So we have a 2-fold concentration improvement compared to other filters. So good filter performance. And I think that's what we're after with epidermal growth factor. Well, I think this is the final note really of performance, right? And this is the examination of the waste products after you filter it out, right? So here we have the testing of the water for 2 really important things, right, that we're trying to keep. One is the soluble TNF receptors, and the other one is the IL-1RA. We don't want it to be in the water, right? We want it to be in our concentration device so we can give this to the patient. So when you look at the data, you see that with the TNF soluble receptors, there's nothing in the water after apex, and there is significant amount in the predicate filter. So again, this is a pore size issue. Some of the TNF receptors just went out with the water because the pores weren't small enough. And this is what we see. We see really good performance with Apex, but again, it's because of the size rather than the standing market. And the same thing with IL-1RA. Again, smaller molecule, there's going to be some waste in the predicate of the marketplace because of the pore size. There just really wasn't as far as the Apex. So exciting that these filters are performing in the way that they were intended. This is great basic science. And now it's time to really launch in the clinical science of this and study the effect of plasma concentration together. I want to leave you guys here today with just kind of a summary of all the things that we talked about. Second column is the apex concentration, and so you could just have a line-to-line comparison to the marketplace, and you see essentially for all of the things that we measured that it was more in the apex. And you can see the fold change in comparison to both the platelet pore plasma before concentration and also comparison to the other filters in the marketplace. So that was the summary of what I wanted to share. Really exciting stuff, right? Because again, this is the waste products of our biologics that are now becoming front and central. Especially, we'll be talking about this more in future webinars about the treatment of muscle injury. That's just one of the big things, but also really, again, creating highly anti-inflammatory preparations for difficult patients that are otherwise struggling. So I wanted to thank you very much for joining us tonight. I have another meeting, and so I have to log off and won't be there for at the end for the Q&A. But I want you to know, all of us here, Apex are available to you guys, right? And so let's keep the conversation going together to really figure out biologics going forward. Again, thanks for joining us tonight, and I'll stop sharing my screen. And we'll go to Dr. Gruner, I think, right, Lone?
Yeah, wonderful. Thank you so much, Dr. Dragoo. It's certainly exciting to see the research that's being done and the data that's being collected to advance the field. And we look forward to learning about the continued research that you discussed. To expand on some of this discussion, we're going to go ahead and turn things over to Dr. Marc Gruner. So with that said, go ahead and take it away.
Thank you, Lauren, and great job, Dr. Dragoo and Dr. Mandelbaum. My goal of this conversation today is just to go over, clinically what I'm doing in my practice, and also how I explain it to patients. Then I'll also be touching on adipose treatments and some clinical use cases. So I do have a disclosure. I'm the founder of Limber Health, a remote therapeutic monitoring company. So the two things that we'll talk about is which Dr. Mandelbaum touched based on, which is PRP, and the other one I'll talk about is autologous stem cells, specifically MFAT. So for PRP, Dr. Mandelbaum and also Dr. Dragoo really talked about a lot of the growth factors, so I won't go into too much detail, but one of the things I always explain to my patients is what is a growth factor and how it communicates from a cell-to-cell perspective to have an effect on the cartilage. And I live in an affluent area in Bethesda. NIH is literally my backyard. And I would say there is a lot of researchers and scientists that want to understand how PRP works, especially if they're going to have to pay out of pocket sometimes for something like this. So the way I explain it is three things. And the first thing is I explained that it decreases inflammation. And it does that via the NF-κB pathway. And it actually decreases IL-1, IL-6, COX-2, which I explained is a decrease in the inflammatory cytokines, and it happens at a DNA transcription level. And so this is why it takes several weeks for it to work, and it's not a quick fix for patients. The second thing that I'll talk about is how PRP augments angiopoiesis, which means that it increases blood supply to the area. And a lot of areas like the joint are a harsh environment for living. So I think that's an important thing for keeping your cartilage as fresh as possible. And then the third thing, I always explain to patients that it hasn't been shown to regrow cartilage, but it has been shown to be cartilage protective. And that's by producing collagen and also via the ADAM TS5 pathway being protective. So the way I always explain it decreases inflammation, it brings blood flow to the area, and it is cartilage protective. The next thing I'll talk to them is that not all PRP is the same. And I think, the team earlier really talked about this, but this is a prospective triple-blind randomized control study that showed high dose PRP versus a conventional dose PRP, and it showed better outcomes with a high dose PRP. The next thing I'll touch base with patients about is the efficacy. And there have been many level 1 randomized control studies, including some double-blind randomized control studies that have shown increases in pain and function and stiffness for patients for pain. that the American Academy of Orthopedic Surgeons has came out with a consensus statement. And I also referred to this article. I trained at Mayo Clinic, and this was a really good article that looked at a fragility index meta-analysis of all the randomized control studies showing that PRP was safe and effective for knee arthritis. As far as other use cases outside of arthritis, I'll also talk about tendinopathy. And there's 3 studies that I'll always refer patients to. One is this for glute tendinopathy is leukocyte rich PRP study that was done in Australia. It was a double-blind randomized control study with very good outcomes. And another study comparing surgery to PRP for type 1 medial epicondylitis and showed very good outcomes. The third one, which I don't have here, is it was a study done at Stanford, which showed a long-term improvement. It was a multi-site study for tennis elbow. There was an article published in the PM&R journal a few years ago that took every tendon and tried to get the platelet count and the outcome measures and the studies and talked about if there was a benefit or not a benefit. And I'll say not every area is the same, and that's really important. Some people like putting PRP everywhere, from helping people improve their hair loss for baldness to your toes. And so I'll just say that not every area and every condition will be effective for. And I think looking at this study, it's really been challenging because some areas have been more effective than others. So the next question that comes to my clinic all the time is cost. If a patient's, a lot of my background has been in value-based healthcare, and so if I'm going to charge $1,000 for a PRP injection, I always want to let patients know on average how long it's going to improve their pain and function. So a lot of the studies I'll point out to at least 1 year that we'll see a clinically improvement in pain and function. From my personal experience in a registry that I have, it's about 3 years for patients, especially if they're in the mild to moderate knee arthritis. But this was a study done by Brian Cole in Chicago that looked at quality of life and said, if PRP can improve your quality of life, your pain and function, the value to society is $1,200. So when you're thinking about cost and the value to society, if one injection can last at least a year, I think that's a reasonable value to a patient. So from there, we're going to talk about stem cells. I will not talk about BMAC tonight, but I will talk about adipose treatments. So how do mesenchymal stem cells work? They differentiate into appropriate cell type, replace to generate tissue, and in some cases, specifically animal studies have shown preventing degeneration. There are 2 locations. We can get them from your bone marrow or we can get them from your fat. And this is another study that was published in the PM&R journal that kind of talks about how stem cells work. And the way I explain it is there's mesenchymal signaling cells. They have the ability to differentiate, and they actually die, for example, in a joint within 3 to 4 days, and then they release a whole host of cytokine factors and can communicate to the neighboring cartilage, which can have an effect on cartilage and also on tendon growth. What's really important for everyone on this call to know is that there's 4 different types of adipose. What's legal in the United States is microfragmented adipose tissue. And that has a really good clinical use case because it's thought that it's not only the mesenchymal signaling cells, but the pericytes that have an effect. And so it's the niche, they call it, that has an important effect on it. Secondly, there's been very good studies showing SVF, which is they use enzymes to digest the adipose, but that's currently not legal in the United States, and that is regulated as a drug. And then the third thing, which is done in other countries, which is cultured adipose stem cells. And at Mayo, we had an FDA phase 1 cultured adipose stem cell study, and we showed very good results in that study. There has been some limited evidence. I would say it's more experimental compared to PRP, but There was a double-blind randomized control study done at Rothman Orthopedic Institute for SVF and showed very strong clinical results, significantly higher than the MCID, almost attaining pass scores for some surgical outcomes. And then there was a second study that looked at 3-year follow-up to see how long it lasts for a patient. This is a study done out of USC that I'll bring to patients that looked at mesenchymal stem cells and showing it was very safe for patients. And then, when I think about the use cases for this, I usually think about this study that was done at Emory University and with several other reputable people in the regenerative medicine space. And it was a 2-year clinical outcome study, multi-site study that showed good clinical outcomes in elderly patients. So one of the things that I've always been interested in is the dose of PRP changes as you age, your BMI. There's a lot of factors that play into PRP, but the fact that adipose could have a use case in there's been some studies in a little bit more advanced than mild to moderate arthritis. And then secondly, it has a use case for the elderly patients. The second thing where I've have been really interested in, I have used it I work with a lot of surgeons in Bethesda, and we've used it in meniscal repairs. And then we've also, I've been very interested in non-surgically for low-grade partial articular sided tears or interstitial tears that are small. And there was a study done at Harvard. There was a case series for glenohumeral joint arthritis and rotator cuff tendonitis. But this study really talked about how adipose-derived stem cells could be used for partial rotator cuff tears and the evidence compared to a traditional cortisone injection. And this was a recent study that was done in the Journal of Orthopedic Surgery and Research, and it was a pilot study showing uncultured, unmodified adipose stem cells and its ability to have an effect for partial thickness rotator cuff tears. So here's an example of a patient that I performed this on that had a good outcome. And these are the type of use cases that I'll usually see for the shoulder. So a patient will come in with pain located in the anterior lateral shoulder. They've tried physical therapy. They've tried a cortisone injection sometimes in the past. Specifically in this case, they had some pain with lifting, and their exam was relevant for injury to the rotator cuff. And so I do a lot of diagnostic ultrasound, and in this picture you can see left is medial, right is lateral. This is the skin. This is the deltoid muscle. This is the acromion here, and then you have this subacromial space. And then you can see here, this whole tendon, this white tendon is the supraspinatus tendon. And you can see that there is a partial tear here. And so I think one person could say, is there a role for PRP here? Yes, I think there could be, and that's definitely reasonable. But you can see this partial tear is about 0.5 centimeter. And I think something that has a scaffold that can be useful. These are the types of situations that I'm thinking about considering adipose. And in this person, we looked at it. We talked about that there weren't a lot of studies, but I discussed a few studies, and we did an adipose treatment. We took the adipose from their posterior buttocks, and then using a kit, we were able to inject it into this partial tear. And what I think is really important is not just the biologic, but the entire process. And so I've written some papers on the rehab process that is involved with this. So usually we'll put the adipose treatment into their partial tear. And then what I think is really important is really having a good rehab protocol afterwards. And so we have specific rehab protocols for every condition, specifically if it's tendons or for arthritis. But we break it down to 3 phases. And this is a book chapter that I discuss where there's an inflammatory phase, a proliferative phase, and a remodeling phase. And if I try to take this approach, and this is the approach for wound healing, and how we think some of the processes happen in regenerative medicine. And then I try to take this approach to a rehab program. And so I won't go into too much detail here, but what's really important here is that I usually try to think about those 3 phases of inflammatory, proliferative, and remodeling when we're thinking about a program for a patient. So for this patient, you know, a lot of my surgical colleagues, especially my practice, will make sure they'll have them in a sling for 6 weeks after a rotator cuff repair. I'm not as aggressive there, and I think it's hard to sell a patient on that for a non-surgical treatment. But I will have them in a sling for 1 week, focus on passive range of motion, isometrics for 2 weeks, progress to active range of motion, progressive strengthening, and then advance more shoulder strengthening 6 weeks. And then depending on the sports and activities that they're trying to get to, think about a load tolerance and work with the therapist to think about an appropriate return to play and activity. And so this patient had 3 years of pain-free, has been pain-free for 3 years, and was able to return to sports at week 8 and return to tennis at week 12. So these are what I've been trying to do, and trying to build a registry, build a rehab program, use the best evidence that we have for thinking about PRP and adipose treatment. And I've created a set of rules because there's 53 orthopedic surgeons, and we've discussed a list of rules trying to stick to so we can have the best outcomes for patients. And so for shoulders, I'll use it for low-grade articular or interstitial tears, mild to moderate shoulder arthritis, tennis elbow, golfer's elbow. I had a patient this week actually come in and had a great result for a partial proximal UCL tear, mild to moderate CMC arthritis. For hip, tonus scored 2 or less with not a significant cam or pincer deformity, hamstring tendinopathy, glute tendinopathy. For knees, KL1 to KL3 with no subchondral bone edema if there's an MRI. I try to shoot for a BMI of 35 or less. Patella, quad tendinopathy, focal, this is very important, focal Achilles tendinopathy, because the studies have been mixed, but really I found focal Achilles tendinopathy to be more effective, mild to moderate ankle arthritis, and plantar fasciitis. And when you take account, trying to think about the right treatment, the right condition, putting together a rehab program, we've had very good success. And this is our registry at 1 year, showing a pain improvement of 11 points and function improve at 6 points, sustained up to 1 year from treatment. So that's just a little about my practice and how I explain it to patients, and some of the studies that I'll go over with patients that are in a scientific community like Bethesda.
Wonderful. Thank you, Dr. Gruner. All great information. We certainly have had some questions that have come in regarding adipose, but before we move to what will be a brief Q&A session, we're going to move into the much anticipated topic of cash pay discussions with patients. And there is absolutely no one better to take a dive into this than Dr. DeMers. So we're going to go ahead and turn things over to you, Dr. DeMers.
Great. Thank you so much. I'm going to just go ahead and share my screen, and hopefully we can get this done, and hopefully you can see me there, and we'll get started. So, wow, I am so amazed. That was amazing science bomb, and my brain is boggled. We've talked about personalized medicine and A2M and IL-1RA, as well as the case for use of PRP, A2M, the adipose use, and then how to talk to our patients about this. So, Mark, I also love adipose for those partial thickness rotator cuff tears. That has been one of my passions. So, putting it all together, how do we get these fantastic treatment options to our patients? We always hear, yes, this is all great, but my patients won't pay. And while these treatments are not currently covered by most insurances, I would like to share with you some strategies to help your patients understand the value, and empower your patients to guide their treatment options for these amazing procedures. So we'll be talking a little bit about that. As you know, I'm Dr. Ariana DeMers. I am a board certified fellowship trained orthopedic surgeon, and I have a rural practice. And I've moved away from insurance and I focus on cash-based orthobiologic procedures. So why cash? This empowers your patient. They have autonomy, you have transparency, that you are more accessible. You can personalize that care, and then your patient has an active participation in their healthcare journey. So here are 3 empowerment strategies for our patients. Number 1, educate and inform. Build trust and transparency, and then address those concerns regarding money and provide support. So how do we do this? Obviously, educating and informing, we have to show benefit. We have to show the advantages of cash pay, the fact that they can get their MRI done tomorrow, the fact that they can get their treatment tomorrow or next week and be able to start on that rehabilitation journey sooner, with less downtime, with less out-of-pocket expense if you have a high deductible. And we have to demonstrate the benefits of the specific procedure as well as value. And you can use this and create this using testimonials, because while patients may not trust me, they will trust one of my patients who's already been through it and has gone through and had success. So really using testimonials from your patients as to what to expect can be quite powerful, and I'm going to highly recommend it. What I also do to educate is we start with pre-framing. So creating a welcome video to your practice before they even enter your world about what orthobiologics is, how it works. So all of this great science that we just heard about can be condensed down into that 4th grade, 6th grade, 8th grade reading level to understand. So they are pre-framed, they're ready to understand and accept that this might be a treatment option that would work for them. And then when they get there, before they step foot in our room, we are already identifying our patient's goals, their reason why. Why are they presenting to us today? Why today and not next week? Why today and not next year? And so when we do that, when we pre-educate them, when we teach them about orthobiologics, you are then the trusted authority. And when people know, like, and trust you, they are more inclined to do business with you. And so if we can pre-frame, they are going to be more inclined to say, you know what, I think this is something that may work for me. Next, building trust and transparency. Please highlight your expertise and the safety. Be clear and concise with the cost. Don't beat around the bush or hem and haw about it. Encourage questions. And, I was talking to somebody and they said, my gosh, I love the way you frame that. Not do you have any questions, but what questions do you have? And the power of words is very important, because one is a closed question where they're going to say, well, I guess I don't have any. But if you're asking them from an open-ended question, what questions do you have? They're much more likely to actually ask the questions, and then give them multiple ways to access that information, and be very clear on price, be very clear on the pricing structures, and just spit it out. I use our data collection to be able to highlight my expertise. So this is my patients. 95% of my patients are satisfied at 6 months of treatment. And so ultimately, we can talk about that. We can also guide their expectations. These are my patients over the last 18 months. This is a numeric pain scale. And we can say, listen, here we are, and we expect all comers, all applications, that over the next 18 months, if you choose this treatment with us, you're going to have a decrease in pain and an increase in function. Next, about the money. You just have to say it. the price is the price. It's just like a loaf of bread. The price is $4. It's not inherently cheap or expensive, and it's just the price. Don't put your judgment of what is cheap, what is expensive, your thought processes of around money, and don't guess what is in your patient's wallet, because honestly, we have no idea. And then we have no idea how much this treatment may be worth to them. Provide the opportunity to know and let them decide the worth and the value of the treatment that you're talking about. So when we're talking about cost and their concerns, obviously we always want to go ahead and blame the insurance company for not covering these amazing treatments. You know, when asked that question, well, why does my insurance not cover it? Said, well, unfortunately, they don't value this treatment regardless of the mounting evidence that it is in your best interest. Again, you know, you can talk about financing plans or payment options, but most importantly, tying back the treatments to their goals. You're allaying their fears. Maybe they're nervous about needles. Maybe they're nervous about the procedure, and then guide their decisions based on their goals, the why, based on their why they came into the clinic today and what this treatment may allow them to gain. So what I always tell people is, please don't sell the bridge. People want to be at the destination. This is the San Francisco Bridge. And when you're driving over the San Francisco Bridge, nobody wants to know how many guy wires and bolts and you know, light posts they have. You don't really care about the how. You want to know what it's like on the other side, what it's like when you're going to get to San Francisco. How's Ghirardelli Square? What about Fisherman's Wharf? That's what we're talking about. We're selling what happens after the procedure. We don't want to talk about, well, we have 10 billion platelets and you know, this many blood spins and at 3,500 RPMs. You can touch on that to differentiate yourself, but ultimately the patients want the destination. They want to know that when they choose this treatment, they are going to get X outcome. They're going to get the other side. They're going to get to the other side. So knowing, liking, trusting will help patients do business with you. So pre-framing, a goal-oriented consult, get the correct diagnosis, which is imperative. Give them all the treatment options. That improves your transparency from non-operative to surgical intervention. Talk about the price and don't bumble it. Don't stumble over it. The price is the price. The price is $3,000. End of story. And then stop talking. You don't have to explain why the price, how you arrived at that price, what goes into that price, and then you schedule the treatment that they need and deserve, because you are the path to reach their goals. So empower your patients through autonomy, transparency, accessibility, and personalized care. And then a little plug. Don't forget, if you want more about the business side of orthobiologics, you can subscribe to my podcast. I'd love to see you. Thank you so much.
Wonderful. Thank you so much, Dr. DeMers, for giving your insight. Obviously, you have a lot of experience with this and have built a successful practice. Dr. Gruner, I know you're in the same position. I figure since we had just talked about cash pay, maybe just to dump into a question, I know we're getting a little extended on time, but maybe like a cash pay question and then go into the adipose protein concentrate question. But you had mentioned about using a satisfaction report to highlight your expertise. What do you recommend for those that are just starting out? Would it be getting a patient testimonial, putting that on the website? What does that look like?
Am I first or
You can go first.
okay.
In.
So I would say that the first step is thinking about the use cases that you want to offer and maybe having a few patient testimonials and thinking about how you want to put together like a package for it, like a brochure. You know, one of the things that I have, I created a brochure. When patients come in, there's a regenerative medicine packet so they can learn more about it. but creating some type of process would be, I think, would be a good first step. The second step, which I think is, I think patients really enjoy, at least in my community in Bethesda, is, building a registry. And so collecting pain and function and outcome measures. And then, when a patient comes in, you can explain based off of, patients coming in with, this diagnosis, there's this chance that I think you'll have a good outcome for this. And I think patients like hearing it from a larger scale sometimes too.
Absolutely. Absolutely. I can't agree more. I do want to be respectful of everybody's time, and so there are some other questions. If that's okay, we can kind of run through. There's a question regarding, are there any articles on comparison of PRP alone, plus or minus A2M, or bone marrow comparisons? That's pending. So please stay tuned. Those papers are pending. We don't have those currently. And then from an updated article regarding who are good candidates for that plasma concentrator A2M, like Dr. Dragoo said, this is a very potent anti-inflammatory, and think of it more of as a scavenger. So scavenging those proteases, scavenging those inflammatory proteins within the joint is one of those things that you can really think about how it works, or the applications, such as an inflammatory application, someone who has a frozen shoulder, or inflammatory arthropathy with recurrent effusion. So I think those are some good applications for this product.
And I think there's something on there. I was just going to say about the success with workers'
Oh,
compensation.
yeah. That was my last one. So there was also a question from the business perspective about, have you had success with workers' compensation cases? This is one of my favorite, honestly. Kind of across the board, I've had, number one, great success. The only tip I'll tell you is make sure you get the agreement upfront and payment upfront. Because otherwise they're going to kind of be problematic, but they do value it and they do know the literature. And so then when people say, well, why does work comp cover it and insurance doesn't? Workman's comp is very interested in getting the worker back to work. And if they don't have to pay for a big surgery and a long rehabilitation, and all they have to pay for is this injection and a pretty expedited return to work, they value that a lot. So this has been really, from my experience, quite successful.
Great, fantastic. I know, as you had said, we want to be respectful of everyone's time, certainly. So if there's any questions that do come in or something was unanswered, certainly I'm going to show my email here. But that is all the time that we have for Q&A section of this discussion. So we are excited to announce that we've entered into an agreement with Jointech Labs for exclusive distribution of Mini-TC adipose processing system, which many of you are probably familiar with. It has been on the market. If you're interested in learning more about Mini-TC, please contact your local Apex representative. As well, Dr. Ariana DeMers shares every Thursday live. She has procedure-based learning and virtual patient demonstrations where she can answer any questions you have related to procedures and talking to your patients about cash pay. With that as well, we are going to be starting labs September 8th. They are complimentary, so we're excited to offer lipoaspirate training, bone marrow harvest training, as well as PRP and protein concentrate. So again, that is September 8th. We just do ask, because it is something that is complimentary, that you RSVP within, or at least a week in advance. Again, here's my email that you see here. Certainly, if there's additional questions that you have for Dr. Gruner, Dr. DeMers, and Dr. Dragoo as well, please send those our way, and we'd be happy to get those answered for you. With that said, thank you so much to our panel. We greatly appreciate it. Thank you very much to everyone that has attended. Certainly with the questions that you guys sent in, it makes it a more interactive discussion. We look forward to seeing you guys next time. With that, have a great evening, everyone.
Thank you so much. Take care.
Thank you.
Thank you.